go.
Okay, looks good.
Okay. Getting it ready to stream live on YouTube for us.
Good.
Oh. Angela.
Good morning.
Morning.
Good morning, everyone.
Good morning.
And screen sharing should be enabled. And also, just as a reminder, we're live streaming this to on the CTDSS YouTube channel.
Thanks, Brad. Martin or Bree or Winter, are you planning to screen share today, or do you want one of us to take it?
Yeah, I'm pulling it up now.
Great. And as that's coming up, I think we'll just want to thank everyone again. And Carson just asked folks to put their names and organizations in the chat. Just appreciating everyone's presence and continued engagement here as we work through details and hopefully respond to some of the questions and comments that you guys are raising. And I will turn it over to, I think, Martin or Angela to kind of kick us off further.
Sure, I can take the first couple, Martin, and then hand it back to you. So thanks everyone for joining us as always. I think when we reflect on where we've been and where we're going, we're nearing the end of our design work on the overall maternity bundle payment program. However, the core focus of the work left is the payment methodology and financial calculations around the program, which really are in fact the core foundation of the program itself. And so want to acknowledge that the work over the next few sessions around this this payment work will be both very important, but also start to get more technical than some of the conversations we've had so far. So please don't be shy about asking questions, jumping in if you don't understand something, and we want to make sure that we're all working together and all feel comfortable and confident in what's being proposed and reviewed. So next slide. So I'll turn it over to Fatmata to give a brief introduction on brief overview of where we are on the doula integration work. Then I can take it back to talk about the equity lens piece and grounding the rest of the payment methodology conversation that we're going to have in the equity lens. And then we'll hand it over to Martin for the rest of today's conversation.
Thank you, Angela, and good morning, everyone, again, and thanks to you for continuing with us in this work. I just wanted to give a high-level quick announcement, as you all know that we're including doulas as part of the bundle. So in order to be successful with that integration, DSS and Community Health Network of Connecticut recently selected Primary Maternity Care, which is an organization that's based in Connecticut, to do the doula integration work for us. And they are partnering with Health Equity Solutions, another Connecticut-based organization whose vision is to attain optimal health regardless of race, ethnicity, and socioeconomic status for all Connecticut residents. So we have two powerhouse organizations working on this program for us, and they have specific objectives to really establish a relationship between doulas and OB and nurse midwives. They are to build the foundation for longer term sustainability of doula services in Connecticut, and also develop a model that we would work off of as we continue in this project. We have started the kickoff phase already, and that will go up to January 2023. And the planning and implementation phase will starts now and will continue through March of 2023. As you can see, there's some current activities occurring as we speak, but you will be hearing from them directly because they will be giving periodic updates to this group and the provider payment subcommittee, the commissioner, DSS leadership, and the legislative oversight body. So stay tuned because we will come to you occasionally with updates. Thank you again for your contribution and your commitment to this work. And Angela, I'll hand this back to you. Thank you.
Thank you, Fatmata. So before we dive into the detail of the payment methodology, wanted to just reground this group in the language around this program and what components would be included. So as you may recall, the bundle will include services incorporated in the pregnancy, experienced during the pregnancy phase, services within that happen around the delivery, as well as postpartum services for the birthing person. The newborn services will be included for reporting purposes only out of the gate, and DSS will look to incorporate newborn services within the overall program shortly after program launch. Today, when we talk about the payment methodology, Martin is going to focus largely on the prospective payment portion, as well as talk overall about the bundled payment pricing itself. And so just want to make sure that we keep coming back to this lens of when we're talking about the overall bundle pricing, it includes the teal, the orange, and the postpartum lime green. When we're talking about the prospective payment, it's going to be a subset of services around the pregnancy and a subset of services of the postpartum period. Next slide. Also just wanted to reground us in the overall program goals and how DSS will define success for this program. DSS is looking to outcome measures that will demonstrate reductions in adverse maternal outcomes, in NICU utilization, in NAS, both overall and opioid specific, and in overall and TSV C-section rates. The lens with which the DSS is aiming to achieve those goals is very much through trying to close gaps in racial disparities in outcomes and in service delivery, to support parity between provider types, including OBs and midwives, to introduce access to doula services, community health workers, lactation counseling, and other supports, and to have a focus on improving the patient experience of care, and also to structure the payment methodologies that will improve equity across the program outcomes. So as we keep going through the conversation today, it's that last bullet point around how can we, how are the payment methodologies structured, and keep coming back to how can we tie that structure of the methodology back to improved equity. And so on the next slide, we have looked at, Martin will talk in detail around the payment methodology, including the prospective payments, the overall episode pricing, and the retrospective reconciliation for the bundle that includes risk adjustment. And in thinking through how that ties to equity, have aimed to give specific examples here. So in the overall payment methodology, and this actually goes back to a lot of the work that this group did together and provided feedback early on in the equity lens and defining specific interventions that could help drive that equity lens around payment methodology. So the overall aim is to align clinical and financial incentives that will improve overall performance and quality outcomes, both in the aggregate and when stratified by race and ethnicity, and that when this payment methodology is implemented, DSS will continuously review and monitor the impact of the payment methodology on those outcomes to ensure that the model is in fact driving the intended outcomes that DSS hopes to achieve. When we think about the prospective payment portion of the payment methodology, the goals there are to create more flexibility for providers in providing some upfront capital to invest in outcomes that can in care delivery to better achieve the outcomes, and in particular to focus on the doula supports, lactation supports, and other services that we've talked about multiple times with this group, to try to incorporate and really build as a foundation of the program. The episode pricing piece, one of the key equity initiatives would be looking to adjust around a blended price approach for C-section rates and monitor the outcomes. So the detail is still being worked out there. And when we think about the retrospective reconciliation and risk adjustment, there's been a real focus to figure out a meaningful risk adjustment methodology that factors in social determinants and socioeconomic disadvantage to make sure that providers who are serving a disproportionate population of folks who have high social needs have appropriate budgets of the bundle to do so. Before we dive into the details of the methodology, and I hand it back over to Martin, are there any other considerations or interventions specific to advancing the equity goals of this initiative that relate to the payment methodology that folks around this table would like to add to this list or amend in any way?
This is Mark. I can't find my raise hand feature.
Please chime in.
Thank you. So in the episode pricing, it says consider adjusting pricing for blended price of deliveries and/or reduction targets. Will you be getting into that further in this meeting?
Martin, can you remind me if there's some detail about that in this conversation, or if that will be for the next session?
No, we don't have much detail on exactly how that worked. We do have a couple slides showing differences between vaginal and C-section pricing, but we don't dive into how the blend will work.
But the assumption is that you'll create a single blended price for a practice based on a mix of C-section and vaginal births, as compared to, say, what I understand the comptroller's office program looks like, which is to have a separate target price for cesarean versus cesarean after attempted vaginal birth after cesarean, or for or based on other characteristics, or as compared to, say, a traditional vaginal birth.
Yeah, I was just gonna say we haven't finalized exactly what those details will look like, but I think we've said it would be a blended rate between the C-section and sort of setting a target price for a blended rate between those two. Exactly how that's done, and I think Mark, you're alluding to like the state employee health plan doing things a little differently, and I'm not sure we would follow them exactly, but we will plan on bringing those details of exactly how we'll do it to everybody. But that was kind of the proposal, is adjusting this blended rate, knowing what the general C-section rate price is, as well as the vaginal delivery price, and then setting a mark between those two to hopefully incentivize more vaginal deliveries when appropriate.
Thanks, Brad. So I asked just, so I recognize there's reasons not to do things lockstep with the comptroller's program, and a lot of the innovations are much more equity oriented than what the comptroller's office used. Do you know whether have there been concerns expressed about perhaps having an undue incentive to not do a cesarean when indicated in order to succeed in the blended price? How much of a concern is that?
So we haven't necessarily, I think those have actually come up in this meeting and previously, in terms of concerns about, incentivizing C-section or, fewer C-section rates. I think it's pretty clear that we're obviously doing more C-section rates currently than are needed. And that, I think, is kind of the baseline, meaning that, if that's our baseline data, then aiming for, and that's how we're setting some of our benchmark cost of, total cost of care, then just by blending those two rates, it will incentivize financially at least a decrease, which is now, obviously there's no financial incentive to not do a vaginal delivery over a C-section. So obviously there's always a concern, and so I think it's something we have to keep in mind. But I suspect if we were, I think it'd be a different conversation if our rates were, if we had if we are already at what the World Health Organization has said is like a real, a good C-section rate, then that would be obviously very concerning. But since we're pretty far away from that, and we're going to set that rate based off of our historical utilization, which I think we all acknowledge is higher than it should be, then that creates a pretty safe space, I think, to incentivize appropriate utilization of C-section rates. Obviously, something we'll need to be monitoring.
Okay, thanks.
Cody?
Yes, hello. I'm not sure if I'm new to these discussions, but apparently in this model, this looks like this reimbursement is going to go directly to providers. Has there been consideration on reimbursement to community health organizations that are providing doula and lactation services, or is this reimbursement only going to go through medical providers in a hospital system?
Our payment model is based for outpatient providers of services, and that's who's the accountable provider in this case. We won't be adjusting payments to hospitals, and we've also said we would be holding providers not accountable for hospital price variation at, I think, the last meeting we had.
Thank you.
And I should say price variation for same services, not price variation based on different types of service, if that makes sense. So it's price variation between a C-section one hospital versus a C-section another hospital for the same service.
I understand. So as far as accessibility to these funds, you would have to be a medical provider. Community health organizations would not be able to get reimbursement for these services separately.
Yeah, and I mean, if you're kind of said it as for ambulatory
Right.
maternal health providers, certified nurse midwives, OBGYNs, family medicine providers that are delivering these services.
But I think, are you asking in particular about the doula community health worker services?
Right. I'm thinking of doula community health workers. I'm thinking of, breastfeeding peer counselors, because many of these services are through a community health organization, not necessarily a hospital organization. So I'm thinking about accessibility and and these services are already integrated into the community, but may not be integrated into the hospital system.
Fatmata, do you want to describe a little bit more about the work that you're doing and how that relates to this?
Absolutely. Thanks, Angela. Yes. So Cody, welcome, since you're just joining these talks. So this is why we're doing the doula integration work, because we're adding doula services and breastfeeding supports for the first time as part of a payment methodology. So in order to strengthen that relationship between doulas and the providers that Brad had mentioned, the family medicine providers, the OBGYNs, the nurse midwives, because they will in essence be the bundle managers, and they will be getting these funds, and the funds will flow through them to these various non-clinical providers that you just mentioned, the doulas, the CHWs, the CLCs, IBCLCs. So that's why we're doing the doula integration work to make that relationship, develop it in a way where the value of all of these other providers, will be seen by the burden people's providers, and just make it work seamlessly. I hope that helps. And if you have any additional questions, you can reach out to me behind the scenes as well.
Yes, no, thanks for clarifying.
Thank you. So I think I will turn it over to Martin to dive into more detail on the payment methodology, and if folks have more ideas on tying it back to equity as we go through the discussion, don't hesitate to chime in.
Sure. Thanks, Angela. So just talking more about the prospective payment methodology, the services that'll cover and its goals. The goals of the prospective payments, they're designed to give providers some upfront capital to encourage some flexibility in how they deliver care, specifically to incorporate doula and breastfeeding services, and also to change the payment methodology with the goal of changing provider behavior to increase the impact on bundle outcomes by increasing provider accountability and flexibility. So it's both to include some of those doula and breastfeeding supports services, as well as to give the providers flexibility in achieving good outcomes for their patients. The principles for the services included in the prospective payment. These are the services that are being considered for inclusion in that prospective payment. Those would be the in-house services provided by the accountable provider. So that would be the OB, the licensed midwife, or family medicine provider. And that would only include the in-house services provided by them. So that would include in-house labs and things like that. Then it's also services that predictably happen during pregnancy or that should happen during pregnancy. And also those high value services like doula supports and breastfeeding supports. So it's only a portion of all services that will be paid prospectively. The services that are included in the prospective payment are a subset of services in accordance with those principles for the pregnancy and the postpartum segments, like that graphic showed earlier. And then in the retrospective reconciliation, which is a later step in the process occurring after the delivery and after the postpartum period, that will include all the services for the pregnancy, delivery, and postpartum as they're outlined for the program. And then for newborn, that will only be a reporting component for program launch. And that's the case for at least year one. So then diving into a bit more detail around the prospective payments. As for timing, the prospective payments, the current plan is monthly, and that is based on a recommendation from the provider subgroup. After the payments are initiated, all the subsequent claims meeting the services included in that prospective payment criteria will not be paid at that time. They would instead be paid through the prospective payment. And at program launch, providers will continue to bill all claims as usual to demonstrate services provided to the beneficiary. Karen, you have your hand up.
Yeah, since the additional services that are included in the prospective payment are not billable currently, is there a plan to track those services and whether or not they are provided to the patients? So things like lactation support, doula services, all of that.
Yes, we're working through figuring out some way for those to be reported so that they can, so that we'll have documentation of them.
Okay, thank you.
All right.
This is Mark. I have a related question. Do you will providers have to submit shadow claims for the doula and breastfeeding support services?
I think that's still kind of to be determined how we're going to collect that data. I think related to kind of what Karen just said is, and Mark, when Karen asked and Martin said, is we want to be able to collect that data, knowing there's some limitations in some of the existing codes that can be billed for those. There's actually new doula CPT codes that will be enabled next year. With that said, it may not provide the level of data that we're looking for. I mean, we are evaluating what would be the best mechanism to do that. We currently collect data on a encounter form for OBP for P, so that's something on the table for us, but we haven't landed on exactly what that will be in terms of a solution. But it's so shadow claims for those are a question mark, but I think we'll have a decision that hopefully makes sense, or something we can present to you in the next few meetings on that.
And it's not known, Brad, what CMS would require, say, for, for actuarially sound, for lack of a better word, partial capitation or what have you, that that they might require some evidence of utilization commensurate with the total amount paid or something like that. That, I assume, something to be investigated.
Similarly, it's Paula Greenberg from Women's Health Connecticut. We don't submit claims for progress payments for obstetrics because of the global. So, are you going to kind of give some guidance for all providers to, generate antepartum billing to get the progress payments or the prospective payments? And then what happens when a mom may miscarry, for example? So, how do we adjudicate those? Because now the bundle's kind of broken. And I think we're going to need clear guidance because many of us have billers in multiple locations. And if we're going to standardize this in a way that makes it consistent, so we're all getting the same payments for the same things, I think those are some things that we really need to have some careful, thoughtful discussion, as well as some consideration of reduction of primary C-section and a blend versus a repeat C-section. I think those are certain things that come to my mind of, what are we going to do? Because we're not, every facility isn't capable of trying a VBAC, for example. I see Fatmata is taking notes there, so I'm not looking for an answer today, but I know we have to have careful consideration of those items.
We agree, and we'll be planning on discussing some of those moving forward. They are very important aspects. And just to say, I think, well, we'll leave it there because I think we'll have to revisit all of these.
All right. So continuing to look at prospective payments, the trigger for the prospective payments, the following text reflects proposed methodology for prospective payments beginning. And our question to you all is, are there any concerns with this approach, and are there any additional triggers that should be included? The triggers that we're looking at now are for the prospective payment to be triggered by a single encounter in either the first or second trimester, and that's tentatively the earliest evaluation and management claim paired with a pregnancy-related ICD-10 diagnosis, and that was the recommendation from the provider subgroup. But as the discussion question says, we are looking for some additional input around what other triggers might be considered, and if there are any concerns with this approach. Karen, go ahead.
I'm just going to raise a concern that I've raised before, which is when somebody gets excluded from the bundle, to ensure that they're not excluded from receiving those wraparound services. That if there is a workaround for that, I think it would be really important, because it's very likely that the people who are bouncing around between providers are people who very much need those services.
All right, thanks. Amy, you have your hand up.
Yeah, I would echo what Karen just said. And I also think, maybe this will be solved because people would be incentivized, I guess, to get people in early, but in a lot of places, either because of capacity or what have you, people aren't seen until later in pregnancy. But some of the models that I've seen that I think do the best at educating people, helping them do that early pregnancy navigation, and also like have wraparound services available should a miscarriage occur and should like clinical services be needed before that first clinical touch point. I think it would be amazing to have at least, again, the wraparound payments be able to start early, and the models I was talking about have like either a nurse or an educator or someone who sees someone and does an initial sort of more education and risk assessment focused encounter. And then the clinician sees them at 10 weeks or something, which is the more appropriate time to do some of the early pregnancy testing and counseling. So that's my thought.
Okay, thank you for that comment. I think those are things that we'll consider as we look at program design moving forward. All right, I'm going to continue on with the slide for now. If anyone wants to come back to that after thinking about it some more, just go ahead and raise your hand. Looking at attribution changes. So again, this following text reflects proposed methodology for ending prospective payments when a member changes their care provider. Are there any concerns here or any other triggers that should be included? So if a beneficiary changes their OB practice after a payment has been triggered, the payments to that practice will stop. If the pregnancy is between a certain amount of weeks along, and we'd like any input on that, if that pregnancy is a certain amount of weeks along at the time of the change, the prospective payment would be remitted to the new OB practice. Mark?
It seems to me, I've thought about this since it was last discussed, that one should simply adopt the same rule as the trigger, which is if the pregnancy is in the first or second trimester at the time of the change, the prospective payment would be remitted. If it's sufficient time to influence a patient's care at the end of the second trimester when they've had no previous prenatal care, it doesn't seem to me that it would be, it seems to me it would be reasonable to adopt at least those time periods for somebody who has had some experience with prenatal care. So I would recommend just adopting that same language in either the first or second trimester. But I'd love to hear from other members of the advisory committee if there's a reason one wouldn't do that.
Thanks for that comment, Mark. If anyone has any further thoughts on that, we would appreciate that.
Do we have a baseline data of how frequently people switch practices? And from my perspective, it's the majority of people, like it happens very, very frequently. So I just wonder, and it seems like in most cases that essentially breaks the bundle. So I'm just curious, like, if that's true, and also how we're planning for that to preserve as much of the bundle as possible.
We are working on pulling together some data around that to help us make decisions in that area. So that is a good question, and it's one we're working on.
Yeah, it's quite common. And I think, I mean, my perspective is from midwifery, where people often discover it as an option a little later on. And so I would want to make sure there's at least mobility, that there's not a disincentive, at least from the patient's perspective, to explore different care if what they're currently getting isn't meeting their needs. And then obviously there's the usual reasons that people move or have an insurance change or whatever.
Okay, thank you for your comment. Amy, you have your hand up.
Yes, I have a question. I just want to be clear. If somebody initiates care, say around 6 weeks early at one given practice, and they're with that practice regularly until around 27 weeks, and then they transfer, does that mean the first practice will get no incentive and it'll all go to the practice that they transfer to?
We're still working out exactly how that would go. But based on the current thoughts on the methodology, the first practice would not be eligible for any incentives or shared savings. If you have further thoughts or feedback on that, we would appreciate them.
I guess my question is, that doesn't preclude that first group from billing just for that antepartum care visit, no different than if there was a breakout of that bundle by a person transferring, correct? That same kind of, it reverts back to traditional billing.
We're still working through exactly, because they would have received some of the prospective payments at that point. We're still working through how exactly that would be paid. We would want to make sure that they are paid for the services that they provide, whether that's through the prospective payment or in a fee-for-service methodology.
I think it would be important for us to kind of look at timelines to understand payment and timelines, and so that we get a better handle on, what are we billing for when, and when are we going to get prospective payments? And maybe the prospective payment gets delayed to accommodate for, a little bit of transfer or, unexpected incidents like a miscarriage.
Yeah.
I can see, money moving around an awful lot.
Yeah.
And it's just, doctors like their money in their hand and providers like their money in their hand, so they have some predictability. And then just moving money creates, I think, added administrative burden on the physician side or the provider side.
And it's tricky, that whole piece of connecting in the first 2 trimesters, one of our patients with the doula service or with lactation education. And if the person may transfer, but then come back to the first provider for the services, the ancillary services that they were referred to. So it's going to be tricky, as but it is tricky.
Yes, thank you for those comments. I think we have some data to look at there, and we'll come back to that point at a later date to see if that helps us inform a decision here. Mark?
I had a question really for Amy Romano about what it means to break the bundle. I was thinking that if for the first trimester an OB is receiving prospective payments that are inclusive of all the additional services, and somebody goes to a different provider for the second trimester, beginning sometime in the second trimester, that the first provider should be able to retain all of what they were paid prospectively, that they provided in good faith. The second provider is then the provider who would be subject to the incentives or disincentives. That is, they are held accountable for the episode if the prospective payment is shifted to the subsequent provider. And so although the prenatal care has been disrupted from a provider perspective, it seems like it doesn't break the bundle, unless you're thinking differently, Amy, about bundle breaking.
I'm not, but I think I was also misreading, or actually it's because this lower hand was over it. I think I was reading it and understanding that the bundle payments would stop and then it would, and then they wouldn't pick up again. So I'm seeing now that the idea is that they would pick up again, but only for certain pregnancies that are within a certain time frame, and that implies that other pregnancies, I guess, it would revert to a fee for service, and that's what I mean by it would break the bundle. I agree that whoever's been receiving those bundled payments, assuming they were adjusted for the timing of pregnancy, and I think I had my hand up because I'm starting to think about sort of trimester-based bundles, and like really because the content and the frequency of the care is very different at these different stages of pregnancy. And so to just have like a monthly payment that's the same every month is going to penalize providers that end up taking care of a lot of people, with late transfers and need frequent visits and non-stress tests and the kinds of things that you see patients for later in pregnancy. Whereas in the beginning of pregnancy, you're only seeing patients once a month to begin with. So I think assuming that the like payment is smoothed in a way that it bundles the care, but then it's like we're kind of already back to like just paying people for the care that the individual visits they're doing if we boil it down too small. So there's a lot of pieces that feel problematic for the scenarios where there's more than one quarterback or whatever for this bundle during the pregnancy, because it's very easy for it to get sort of the wrong attribution, I think, of costs or to disincentivize certain kinds of care.
I'll just put out that there's some limitations on how much on technically in terms of our payment system about how we operate some of these things as well. So there's obviously some limitations on, paying different amounts frequently becomes very challenging to operationalize. And so there's also some limitations that go into it, but and also just noting there may be some individuals who are excluded that may, that may not be included in the bundle because they are so high risk for certain reasons that we've, we talked about a little bit before. So just to say, and also acknowledging that you can bill for things that are outside of those bundled services that are still in a fee-for-service manner. So things that are not included, there's still opportunities for fee-for-service billing. And so just keeping in mind that there are some obviously layers of complexity. I think one thing that will be helpful that Martin alluded to is providing some data about how frequently switching is occurring, because if it's a big issue, then it's something we really need to make sure we drill down on. Obviously, even if it's a small issue, we need to have clear rules and how we're going to handle them, but they may be less important than the rest of it. And I think that will help direct some of the attention as to where we spend more or less time, if that makes sense.
Cody, you have your hand up.
Yeah, and I think it's worth considering how the continuation of care for those wraparound services that people who choose to change providers are not having to develop a whole new relationship with a doula or a peer counselor. That these are, sometimes at-risk women, and it's difficult to reestablish that kind of relationship that might have taken the first and second trimester to establish. So if there's a possible way to continue to have continuity of care for those wraparound services, even if that mother chooses to change medical providers, is something that I think would need to be considered.
Yeah, I'll just say, I think, unfortunately, it's probably not extremely feasible because of how we're constructing it as of now, unless there was, for example, if there's a doula, since we are including that as part of the bundled payment, it's really up to providers to contract or hire, or however, whatever those relationships will look like with the doulas. And so obviously, if the doula was willing to contract with the new provider, then that would be possible. But I don't think it's not something we'll be able to guarantee it based on how this design is functioning, because those payments have to occur within, as of now, within the bundle itself, within those bundled prospective payments.
Right, I recognize that limitation of payments, but it is really worth considering that continuity of care and establishing that relationship is what makes doula and breastfeeding peer counseling so effective, that there is that established relationship. So if we're looking to really address disparities, that's something to really remember.
No, I think we agree that the relationship component and is really, really important. And we're very much, I think, hoping that over time there'll be relationships both with providers and patients that are enhanced, as well as within teams. So with doulas and, OBs and certified nurse wives that may have not occurred, and that will ultimately strengthen how this bundle functions and hopefully get us to improving some equitable outcomes over time. But appreciate the concern. I think it's a valid one. It may probably something will be challenged to resolve right now, but it's obviously really important to consider.
Karen, you have your hand up.
I just wanted to ask for clarification on something you just said, Brad. So the folks who are being excluded from the bundle because they have a high risk status, does that mean that the bundle will not apply to their cases at all, or that there are additional fee-for-service billing allowed on top of the bundle in an additive way? Because I just have a lot of concern about excluding high risk folks from the bundle, given that you're then very likely to disproportionately remove Black and brown women from the bundle. Yeah, so just asking for clarification about that, is if they're also completely excluded from receiving the wraparound services.
Yeah, and I know this has come up before. I don't think we've fully settled on exactly how that will work. Just to say, so say someone's potentially has triplets. Obviously, that's maybe something that requires additional monitoring and support services. I know this is something that's important, that we are still determining how that will be paid out. But you can also imagine that if we have a set rate that is the same, that is risk adjusted, we have to make sure that we're obviously paying appropriately to providers if there's triplets as part of a prospective payment, which, there's some operational challenges that we're still going to have to circle back on. So just to say, we definitely heard that and are interested in making sure that individuals have access to services such as doulas regardless. There's just some logistics of how to actually do that effectively within how we're constructing the payment model and actually just operationalizing it. But yeah, definitely understand, like, if you're having triplets, then you'd like access to doulas, that would be something that we would definitely like to have happen. It's just somewhat operational. Can we facilitate that in a way that makes sense?
Okay, but just again for clarity, you haven't ruled it out. You're just trying to figure out how to operationalize it, right? Okay.
Yeah, it's not ruled out. It's just how do we actually functionally do that?
Got it. Thank you.
Okay, I'm going to move us on to the next slide to continue talking through the prospective payments. Now focusing on termination rules. This following text represents or reflects proposed methodology for prospective payments ending. Are there any other termination rules that should be considered? So if a claim is submitted carrying a code indicating the pregnancy was miscarried or terminated, and then also at 90 days postpartum. So those are the two end points for the bundled payments or the prospective payments rather that we're considering right now. Are there any other termination rules that we should be considering?
What about if somebody has like one or two visits and the payments start and then they move to Kansas or whatever, and nobody thinks to pull them out of the system? It seems like the practices could be on the hook for a bunch of penalties at reconciliation if that happens frequently, which again is something I think a lot of practices have people that you could lose track of that.
Okay, thanks for that comment. We'll think about that one. That one's tough because there wouldn't be a new claim or anything saying that that's happened. But that's something that
Provider education or something. Yeah.
We'll consider that one some more. Karen, you have your hand up.
Yeah, so for folks who do miscarry or terminate a pregnancy, will there be some consideration for postpartum doula services, for example? So there are doulas who specialize in miscarriage and stillbirth and providing support after those events. And I am not sure. I understand why you wouldn't want to continue prospective payments for OBGYN services that would no longer be being received, but wondering if there's any way to think about making sure that those services are still available.
It's a great question. I don't think that this has come up. It may be something that we realistically would be challenged to do at launch, but we can circle around on
it. Cody, you have your hand up.
Yeah, just to springboard off of that, having lactation services available as well for those women because they would need it depending on at what point they miscarried in the pregnancy.
Right. Thanks for that comment. Like Brad said, that's tough to look at least at this point in the program, but that's something that we can look at further down the road. All right, then looking at the pricing of the prospective payments, the prospective payment amount would vary by practice based on the provider specific utilization history in accordance with the prospective payment principles shown on an earlier slide. And that can be due to the different services that different providers have available in-house, whether they have in-house lab and what extent they have that. Any variations in amounts paid prospectively will be counterbalanced through the reconciliation process. And the calculation of the practice-specific payment rates will reflect clinical and social risk adjustment. I'm going to pause there to see if there are any questions before moving on. All right, then taking a look at the retrospective reconciliation process. This happens at the end of the episode. The total cost of care for services provided under the bundle will be compared to the benchmark price. This gives accountable providers the opportunity to be eligible for shared savings for the first year, and subsequent years would include both up and downside risk. Based on maternity related care provided from 280 days prior to the delivery through 90 days postpartum, when combined with quality performance. So these bundles would be reconciled at least twice per year, as often as quarterly. And our discussion point here is twice a year a reasonable timeline for reconciliation? So the prospective payments would be paid during the pregnancy and then the retrospective reconciliation would come in and cover the shared savings component at some point following that. Any thoughts on that time frame? Okay. We did have that recommendation from the provider subgroup, so we'll consider that recommendation good for now. And take a look at equity considerations. So the bundled payment is an opportunity to address underserved population. Underservice may show up as fewer services initially, but can lead to more expensive emergency room and inpatient services, which are not only cost more, but also are worse outcomes for the patient. The prospective payments to physicians for underserved populations can be adjusted to include costs for adverse actionable events that would historically have gone to those ER or inpatient services, and would instead help to prevent those AAE from occurring. This program will also allow for monitoring equality for all populations. And our discussion question is, what factors should DSS consider when implementing risk adjustment for social determinants of health to address health equity? I'll pause there for a moment. Amy Romano.
I'm just, can you say more about the adverse actionable events and what costs? That would just be the provider costs related to those AEs that are essentially getting added to the pot. And like the idea that they would historically have gone to the ER, but through payment alone, they're gonna be handled in the outpatient setting. I think like getting a real understanding of like, is that really because depending on what that is, it could be a substantial additional source of funds to truly do different care in the prenatal period and lean into the social determinants pieces. But I think prospective payment alone is not enough to see things in the outpatient setting that people go to the ER for.
Sure. And so the idea with this is that through this program, we can improve the prenatal and delivery, and then also postpartum follow-up care. And part of that is through the prospective payments. Part of that is through the monitoring of quality. And the objective there would be to reduce those, and they're called adverse actionable events. They can be things like readmissions, complications in care, and they're things that we're hoping can be avoided through better management of the pregnancy earlier, and which would be incentivized by this program. So it isn't necessarily a huge cost overall, but it is, very significant to those patients who experience those readmissions, and the readmissions themselves can be quite costly. So by even reducing those by a little bit, there is a little bit more, a little bit of money available. And it is very difficult to quantify, so I can't say exactly how much that is. And monitoring things like this is, it's maybe somewhere around 0.25% to 1% per year. So it's really tough to tell that from just regular variation, but it's an overtime shift that we'd be hoping to achieve through this program.
The rate of AAEs ranges between a quarter and a full percent?
Not that'd be the shift, the change in a given year. So it's I don't recall exactly what the rate of AAEs is. We have a slide that shows AAE dollars later.
That's helpful. I think like a big area where this could save a lot of money is in ER visits and, pregnancy and postpartum. But I just want to understand how it's sort of being tracked and feeding back into investment in the things that continue, that help us do that.
Sure. And it is tough to say exactly where those dollars are. It's really just a shift in mindset for the program and providing that flexibility and the monitoring that can help to achieve that change over time. Mark, you have your hand up.
Yes, I feel a little dense on this issue with regard to the third bullet. So the prospective payments, if an adverse actionable event occurred, like I don't know, an accidental fall or dehydration or something like that, which are two of the numerous AAEs in the state comptroller's list. Somebody with those conditions might have gone to the ED. Instead, they would show up with a qualifying AAE diagnosis at the office of at the practice, the obstetrics nurse midwife practice.
So it's not necessarily the event itself that changes, but the likelihood of the event. So instead, when that person who is, say, dehydrated, instead of ending up in the emergency room, ideally they went to a prenatal visit a couple weeks ago where their provider reminded them, okay, make sure you're drinking your water, and that it's just some more subtle shifts like that through monitoring and better management of patients, that those AAEs are avoided.
So those AAEs are included in the benchmark price or in the actual prospective payment. So I'm getting a payment for my E&M services and my doula and breastfeeding support in the prospective payment. And I'm getting some additional adjustment that relates to the likelihood of AAEs in the population that I'm serving.
So the AAEs themselves would be included in there's a couple components to it. The overall prices are likely more included in the retrospective reconciliation, because they are largely not going to be like OBGYN costs. They're going to be other types of providers.
But they would be folded in. So if I have treating a population that has a lot of AAEs that I didn't have a hand in avoiding, in the retrospective reconciliation, those visits to the ED for dehydration would be part of the costs that would be considered in whether I meet the price benchmark.
Yes. And the AAEs are also part of the quality benchmarks as well.
Yeah. So then how are they factored into what I'm getting paid prospectively?
Mm-hmm. That's so we haven't made any decisions on what exactly this looks like, but should they be factored in year one, they would look like a shift of likely a fairly small shift of dollars from one component to the other. So from
is the thinking here, Martin, if I can interrupt, that you're kind of giving providers an advance on anticipated AEE savings, that is, so that they have the resources to invest in these precautionary activities to help reduce the likelihood of presenting with dehydration or something like that.
Yeah, and we haven't nailed down whether this will occur in year one or when it might be implemented, but yes, that's the idea of it.
It's an interesting idea. Thanks for explaining it.
All right. We also have some initial data summaries. These might help to answer some of the questions that have come up. I just want to provide some caveats here that these numbers are draft and are pending final decisions on inclusions and exclusions. The numbers include physician, hospital, and other costs and are reflective of total bundled amounts and not physician payments. Except where the physician payments are specifically broken out. And even where the physician components are specifically broken out, we have for now used a very narrow definition of physician because we have not broken out what exactly by practice, what services are considered in-house. So just keep that in mind that the numbers will vary going forward. And these numbers help frame the components of the bundled payment and show some areas where costs can be changed to improve outcomes. And I'm going to turn it over to Bree from our team to talk through the data.
All right, thank you, Martin. All right, so here are some benchmarks for the bundled baseline data. These numbers that are shown on the slide currently represent the percentiles for the bundled baseline data. This table does include all categories of service like Martin referenced before. And this shows potential thresholds for the outliers. So we have not removed like the very bottom and the very top of this yet. This has all the data in it just to kind of show you where we're at. We did split it up into the delivery type. So it is split up into the vaginal delivery versus the C-section delivery. So for example, when it has the percentile of 5, that means 5% of the deliveries for the vaginal deliveries cost under $2,936, whereas 5% of the C-section bundles are costing $3,061. On the flip side, we have at the 95% percentile, 5% of the vaginal deliveries cost more than $14,819. And then 5% of the C-section deliveries cost more than $22,367. And that 50 percentile right in the middle, that's the median, saying that half of the vaginal delivery types are less than $8,038, half of them cost more. And then for the C-sections, half of them cost less than $11,686 and half cost more. So again, just to kind of give you guys some benchmarks before we exclude anything out of this. Right, and then we broke this down into the categories of service for the bundled data. The physician numbers specifically include maternity-related procedures. This table shows the cost variation between vaginal and C-section deliveries is primarily driven by the inpatient and hospital components. So same thing as before, we do have it split up into vaginal versus C-section. Which you can see that the costs are higher on the C-section. We also did the percent of deliveries. There were just about 2/3 were vaginal deliveries and about 1/3 was C-section. And then split in that. So for example, for the vaginal deliveries, for the physician cost, it was $2,353. The hospital inpatient was $3,621. Hospital outpatient was $1,230, and then the other was $1,305. And then the same thing for the C-section. Again, I do want to address that third bullet point that most of it is coming from the hospital inpatient where the cost variation is. And then that blended rate, which was referenced before, that's where we took, given that there are about 66% of deliveries are vaginal and about 33% are C-sections. When we split those costs up in that way, then the blended rate for the physician would be $2,511. It's a little bit closer to the vaginal one, just because there were more deliveries of that type. So that total blended for the entire episode is coming in at around $9,849. Are there any questions?
Are the hospital inpatient costs the physician-related costs or the facility costs?
Martin, just to be sure, it's the facility, correct?
Those are the facility costs, yes.
Thank you.
Okay. All right, and then we have the AAE costs, those adverse actionable events, like we spent a little bit of time on before. So we broke these up into the different stages of the pregnancy. It includes all categories of service. So on the previous slide, we did split it up into the categories. This is bundling them all together. And the AAE costs not only represent increased costs, but also worse outcomes for the patient. Again, we mentioned it before, but we wanted to mention it again. So these are great opportunities to refocus spending on the proactive patient engagement to improve outcomes, both cost-wise and for the actual patient, making sure they're having a better experience. They don't have to go back in for things. So the typical dollars, that's what we would expect that the cost would be. These are expenses that are normal. And then that AAE, that's those are the costs that we're seeing where maybe they could have been avoided if there was better care previously. So for prenatal, an example, the typical was $5,247, whereas AAE had $314. So it still makes a total amount of prenatal cost of $5,562. But where based on the data, we're thinking that there could have been $314 that could have been prevented. And then we did split it up into the delivery and the postpartum to give for the total episode, the typical at $9,238, the AAE at $605. For the total package being the $9,843, or for the full episode. All right, then we have our ADI, which is the Area Deprivation Index. It's a measure for ranking relative income, education, employment, and housing quality between neighborhoods. A low ADI score indicates affluence relative to Connecticut as a whole, and a high ADI score indicates high levels of deprivation relative to Connecticut as a whole. The data are organized into deciles for the purpose of summarizing them. This is just one measure that could potentially inform adjustments for the social determinants of health. How we calculated the ADI was based on the 9-digit zip code that was given to us. There were some patients who did not have a zip code, so those numbers are not included in this data. It's only for those where we had that 9-digit zip code. Okay, so we first have a graph here to show the left side is the total average spending on the maternity bundle based off of that ADI. So to the left, we have the ones and the twos. So those are saying the ones, if a member has an ADI of 1, they're saying that they're in the top 10% of the affluent population in Connecticut, whereas a 10 means that they are in the lower 10%. So again, the lower the ADI, the higher affluence, the higher the ADI, the higher the deprivation. So again, the left is just kind of giving you a visual of the average spending on the maternity bundle. And then we wanted to show on the right, then we just took out that AAE based off the ADI. So as we can see, as we get closer to the higher deprivation, that AAE is trending upwards. Yes, Karen?
I'm curious why the data is not complete, since there has to be a complete address on record, right? So is there some reason you can't find the 9-digit zip, or what? I'm not understanding why some of that data would be missing.
They're just in it, some of it only had the 5-digit zip code, which doesn't allow or isn't good for the model, and there just is some data that did have some blanks. It wasn't a big population, if I recall, but just there was some.
I think your question, Karen, is like, if we have the address, we can probably calculate the 9-digit zip, I believe.
Yes.
Right?
Yeah,
Yeah.
I mean, there's even like easy data sets where you can just do that match real. It doesn't seem like a heavy lift in terms of the data issues that we address on a daily basis.
Okay.
Yeah, I think if we were actually using it to make we probably would want to try to calculate it on it. Obviously, it's not our entire population, so it's a smaller subset, but definitely if we're using it for risk adjustment purposes, this is kind of, I think, preliminary to help us kind of model out, or at least show what might, what the impact of this could be as we're thinking about social risk adjustment.
Okay, all right, and then this gets into a lot more of the data. I know there's a lot right here, so I'm going to explain it a little bit and then let you guys digest it. So we do have it split up into the ADI onto the left. Again, the 1 meaning that it's a relative high affluence, a 10 is a relative high deprivation. That next column is the number of births based off the ADI. Then we have the next 3 columns, the average spending on maternity bundle. This is what was represented on the previous slide on that first graph. These are just the actual numbers. We included the median and then the average AAE, which was the right graph on the previous slide. Again, these are just the numbers, but this is what was represented before. And then we have the actual percentage of births based also on the race and the ethnicity. So for that first column, if it's an ADI, or sorry, for the first row, an ADI of 1, there was less than 1% of the births within that ADI of 1 that were American Indian, Alaska Native, but not Hispanic. Then 4% of those births were Asian, not Hispanic. 12% were Black, not Hispanic, again, of the ADI of 1. There was 0% that were Native, Hawaiian, or other Pacific, not Hispanic. 29% were white, not Hispanic. 44% were another race, not Hispanic. It could have been another one, or that they just chose not to give that information. And then 10% were Hispanic of any race. So as you're looking at each row, those percentages are within that, excuse me, those percentages are within that ADI decile. So if we were to go down to the 10, we could see that there were 22% of births were Black, not Hispanic, 12% of births were white, not Hispanic, 28% of births were other race, not Hispanic, and 35% were Hispanic of any race. So again, I know that's a lot, so I'm going to let you guys look at that and let us know if you have any questions.
Thanks, Brian. I'll just say one of the reasons we thought this would be helpful. So some of you may be familiar, but probably some of you are not, is ACO REACH, which is a CMMI model, payment model, is using ADI for help as one way of doing social risk adjustment in that newly launched model, which is their new direct contracting program, again, through CMMI at the federal government level. And so we wanted to think about whether that would be a useful way for us to think about risk adjusting within the confines of the bundle. And so starting to look at it and wanted to provide you some information as we're thinking about it. Again, this is at the population level, so it's based off of address, and then it takes a ton of data, as Bree already alluded to, that's been validated, initially developed by HRSA decades ago, and has been updated through the University of Wisconsin-Madison periodically to provide at this kind of geographic or population level for possible that you could potentially use for risk adjustment. So just wanted to add that, and thanks, Bree, for already providing that context.
Karen, go ahead.
Yeah, and you may be getting to this in a subsequent slide, but are you applying this to risk adjustment for the prospective payment or for the retrospective reconciliation and shared savings? And I ask in part because any of these risk adjustment methods involve some trade-offs, right? You want to make sure you're not holding certain providers to a lower standard than other providers in terms of quality. And on the other hand, you want to make sure that providers are adequately compensated and not discouraged from treating high-risk populations. So that's where my question's coming from.
Martin, do you want to be more specific on the adjustments?
Sure. So the risk adjustment primarily applies to the retrospective reconciliation. And that's mainly because the data that would be needed for that, especially the clinical data, is only really available retrospectively, at least for some patients. So that's the primary use. I don't think that there are any, I don't think that there are plans for adjusting the prospective payments using risk adjustment. I won't say that that's ruled out, but that it is primarily for the retrospective reconciliation.
So I'm sorry, can you just clarify that? What data would you need other than the address, which you would have prospectively?
I mean, the clinical component of the risk adjustment would be the more retrospective one there.
Yeah, I think it's still, as kind of Martin said, on the table. This is kind of, I would say, still fairly preliminary in terms of what we would consider doing with it. But if you're doing both clinical and social risk adjustment together, then it's more challenging if you don't have the clinical risk. Again, we often will have a lot of information on some of the members, but some of the folks we won't. And so that creates some challenges on the prospective risk adjustment. And then do you apply that more retrospectively? So there's some decisions that still have to be made on how to apply it and where.
And just one last follow-up on that. Is it possible to consider using the risk adjustment for the final payment calculation, but not for whether or not the provider meets the quality benchmarks? Isn't there a quality gate before you get to the shared savings?
Yeah, and we haven't kind of gone through the details on how that would apply. And so I think what you're asking, Karen, correct me here, is like, is there a risk adjustment in terms of your outcomes on the quality scores? Is that right?
Right. Are you risk adjusting for all of that part of the the methodology, or are you risk adjusting only after you've determined whether or not the quality benchmark was met?
In terms of the social risk adjustment, I don't think we've really weighed in. Typically, clinical risk adjustment is done, but Martin, please feel free to weigh in.
Yeah, I think in terms of quality metrics, some of them might be appropriate to use risk adjustment for. We haven't evaluated that, so I can't say anything for sure at this point. Right, Mark, you have your hand up.
Yes, unless I missed it, Martin, I'm assuming this is the same chart that was presented to the payment group, and that this is not adjusted for outliers for clinical risk adjustment or for facility price.
That is correct, yes.
Okay, so I raise it, not to be redundant, but in the interest of the broader advisory group, just to say that for me, I'm interested in the extent to which the area deprivation continues to explain some of the variation that's seen after you've accounted for facility price and clinical risk adjustment. So other factors may be explaining why the 254 are so expensive from a maternity bundle perspective. For example, they all go to UConn John Dempsey, or they disproportionately get their services from UConn John Dempsey, which is substantially more expensive. So anyway, it would be certainly of interest as you get to a decision about how and whether to use ADI, to see what additional explanatory value it provides after you've applied the other adjustments.
Yeah, thanks for that comment. And this and any other measures of clinical and social risk do have to be considered in light of other things like variations in facility payments. So that's a really good call out. Right. Our next slide is just one requesting any questions or additional feedback. And if there aren't any, I believe we are at time. Brad or Fatmata, any closing comments? I'll say thank you all for your questions and attention today. And Brad or Fatmata, anything further?
Nope, just I really do. Always we do appreciate it. We know that there's a lot of questions that still are to be resolved, and we'll work on continuing to answer those and bring them to you guys. So thank you again for your involvement, engagement, and questions. Fatmata or Angela, anything else?
No, Brad, just concur with everything you've said. Thanks to everyone for coming. Bye.
Wishing you all a happy Thanksgiving.
Yep, great holiday, everybody.
Thanks.
Happy Thanksgiving.
Thanks, everyone.
Thanks.